Thank you so much for having me, and thank you everybody for making a little time. I really hope that we can to have a conversation later because I know that probably I will be preaching to the choir. Many of the things that I will say, I know that you have seen, you have heard, and so I hope that we can talk a little bit and go deeper in look what does this mean. So I'll share my screen now. And then the title of the presentation, you saw it in the article, in the announcement, Understanding Motivations, the intersection of myth and reality in Alzheimer's care among Latinos in the United States. So a couple of disclosures to start. I have received funds. I will present several parts of the project that has been really divided in multiple little parts. And I have received funding from NIA, the Wisconsin Alzheimer's Disease Research Center, and also part of the ICTER, the CTSA here at the University of Wisconsin, and the Wisconsin Partnership Program. And I'm really grateful to anybody that has supported me. And this is not only my work, but the work of my whole team and many other people. So a few of the things that we're going to be talking about. First, exploring motivations to seek care. Then understanding how did we explore these things, a little bit of the methods, what we found, and future research. So the first thing I would like to start, we have a chicken and the egg situation. So again, I'm in Wisconsin. Wisconsin, we have 6% of Latinos in Wisconsin. So it's always like, well, do you guys have Spanish-speaking staff? No, we do not have a speaking Spanish staff. Then when you don't have a clinical resource with the resources to diagnose Alzheimer's, people don't ask about it. But then because people don't ask about it, then they are also not getting staff members that are adequately trained to provide the diagnosis of Alzheimer's in Latinos. If somebody doesn't have a diagnosis, then they cannot get additional services and resources. So the clinics cannot, at the same time, cannot get prepared to provide the service. So we have in this situation that we always go back in circles, like, but there's not an offer, then there's no demand. We have demand, but there's no offer. And we keep going back and forth of where do we start? And usually this, here's where I started talking about, let's talk about motivations. Let's talk about the first step. Again, thinking in business terms, offer and demand. Let's talk about the demand, the motivations. When does somebody go and seek care? There's 1,000 different types of behavioral theories out there, but this is the one that I have used in my work, that this is the theory of planned behavior. You can find it in this website, but basically this refers that in order for somebody to do something, and here I will refer to this little behavior purple square, to do something, in which case, this case I was talking about seeking care for cognition or memory problems. First, they need to have the intention, right? They need to be motivated, like I need to go there. But that intention is affected by three things. Number one, beliefs. And this is not only knowledge affects belief, but what's a belief? And I wanted you to think, when I say the word belief, we think about religion. We think about the things that we believe are true within our body. But also it refers to attitudes. Is something that, should I do that? Is this good for me? That also affects what are the beliefs that we are referring to now. Then the second thing that needs to happen is also normative belief, or the norm, what people consider normal, what other people will encourage us to do in order to do something. And here is where I'll give an example. We're talking about exercise all the time. Now think about that behavior, exercise. I need to believe that the exercise is good for me in order to feel motivated. But also I need other people to tell me the same thing as expectation, like, yeah, exercise is normal. But when we start getting into things like, again, little different, like vaccines. Do you remember the COVID-19 vaccine conversation? Oh, no, but in my family, nobody believes in vaccines. So if people around you do not believe certain behavior or activity is good for you or will be beneficial for you, you might not be motivated to seek that or do that, right? And then we have the last component, which is, can I actually do it? That's the control beliefs. Do I have the tools at hand to actually do this that I want to do? And this is the theory. But let's look how this looks like in real life, because it sounds very nice, but it's actually more things involved. So in an ideal world, we should have memory changes. Somebody has noticed any symptoms, like this example, where did I put my glasses? With 7 different pair of glasses around her. They want to go see the doctor, they go to it. But in reality, we know that this is what's happening. So somebody start having some symptoms, and you have seen this. The first thing that, and this came from a lot of the interviews that I have done, the first thing is that people starts to do something about it. What's that something? They have post-its. They start to have reminders themselves. They have to take notes. They have a little book that they use to make sure that they don't forget appointments. They start to take supplements or talking with family members to say, hey, I'm having this. And hey, my comadre in Mexico recommended this root or this tea for memory. And they start to do things that they have identified as potentially helping those symptoms. Eventually, when the symptoms continue, they start to evaluate, do I need to go to the doctor? But this conversation is not just like, oh, yes, I need to go. It's a lot of back and forth. Oh, it's probably nothing. This might be just stress. I'm just getting old. I just need to keep an eye on this. I don't know. Maybe this is nothing. Maybe I should not mention it next time. But then eventually there's a point where people say, yep, nope, I gotta go. It's time to get seen. But then the conversation is different then. The conversation is, do I have insurance? Is my insurance valid for this doctor? Where do I go? If there's a copay or medication, so they need to do a test, do I have money this month? Or will I be using my food money or the utilities money in order to get seen? That's a little of the part of that motivation. Do I have the means to get to the doctor? Then let's assume that everything is good. But now we start to organize these resources. And this is where I call the telephone game. You call the doctor, waiting for somebody to pick up. Oh no, the person that scheduled the appointment is not here. They called you back. Then you wait in line, they drop your call, they call you back, but you cannot pick up. And then these 3-4 days that you cannot make the appointment. I am a physician. I speak English. I have insurance. It takes me 3 weeks sometimes to set up an appointment with my primary care doctor. If me that I have all the privileges in the world have such a hard time in organizing my resources to make one appointment, what can be said for everybody else? And this is part of what I do, the work that I do. Access to care is not just, oh yes, you get an appointment in 6 months. Access to care means having the right care at the right time, at the right place. It is not useful to get care that is not what you need or when you need it. Or worst case scenario, that is not where you need it. If in order to receive the right care that you need to drive 3-4 hours down the road, is that really accessible? Is that really something that is what you need? That's part of the conversation that we're going. But we know, again, coming back to the example that I just gave, this process is affected by culture, education, literacy, language, awareness, socioeconomics. There's so many things that affect this process of thinking about motivations, but not only motivations, but the intention and the actually getting to care. That's part of what we do my research about. But let's explore now some of the things that we think we know about motivations of care. And this is where we go, the myths and realities. So most of the results that I'm going to show you today have not been published, so I really appreciate if you want more of this information of the slides, I'm happy to share, and you can see the video. But the publications will come in the future. So the first thing that we collected data using interviews, a qualitative study using elucidation techniques. These interviews were with older adults. We ended up doing 23 interviews with 65% of them were women, most of them between 50 and 87 years old. We used this card sorting technique. We gave them these cards, and then I started asking questions about the topics of the card. You might be wondering, why do you use those cards? I don't know, for those that have done qualitative research, just asking, what do you think about dementia? People start like, what? I don't know. Then the purpose of these cards is just to have a conversation started. So we gave them the cards and they started saying, okay, look at these words, look at these things. Now, could you group them? What are the things that are similar? What are the things that are different? What are the things that are the most important to you? What are the most dangerous or the worst things in these cards? And then people started arranging these cards in multiple ways. The cards are just a conversation starter. Is to give people something physical that they can touch and they can move around. So if you say, hey, diabetes is worse than high blood pressure, or depression is worse than diabetes. So you can give them things that they can physically start moving and seeing, and then that's a conversation starter. And I really love this technique, honestly, best thing ever. The second thing that we did was we use a validated instrument that we validated ourselves. It contains 47 items. It's available in English and Spanish. It takes about 13 minutes to complete in average. It could be done as short as 6 minutes. Most people took about 15, 16 minutes. This was distributed online, in person through community events and a group of promotoras in LA. And it was applied in Chicago, Puerto Rico, Houston, Wisconsin, and LA. With also the online distribution that we hope that it really reached all around the US. This survey was validated, and the purpose of the survey was asking the same questions. It had questions about knowledge, some questions about culture, and questions about motivations to seek care. When would you go to seek care? And what are the important things that would motivate you to seek care? Well, let's go a little bit. One of the things that I like to emphasize here, doing an online survey to ensure that the responses are authentic is very important. We offer an incentive of $15 for completing the survey. That means that we got a lot of interest, and sometimes from people that was not eligible. So we had, in total, 17 different checkup points to make sure that these were not fraudulent responses. These are just the six that one that I want to mention around. We have the CAPTCHA. We have exact sentence replication. If it were a bot, this will be fill out some gibberish in that sentence. Where basically we say, people, please write this in the text below. We use for a fraudulent score from Qualtrics, with that measures IP, making sure that it was not from a computer or device that had already completed the survey. Mismatch between the name and the email. If somebody said John Smith and then have an email that was John Smith 1 2 3 4 5 6 7 8 9 10 10 10 10 10, that was a little concerning. Or that they have used random numbers and letters. That's another concerning. Response type, responses that took a long time or very, very short time. Like, oh yeah, they fill out 47 responses in 1.5 minutes. Yeah, there's no way. There's no way, period. So that's another fraudulent response. And finally, abnormal behavior. So these are responses that were submitted in batches for suspicious IP addresses, or that there were some other elements concerning in the actual survey metadata. Final response. We got 1,019 individuals completing the survey. And I'm very proud of this because the last time I checked, this is the largest survey about knowledge of Alzheimer's in Latinos in the US. So 42% of the responses were in English, 58% in Spanish. We got a pretty good mix there. We got a pretty good mix in ages. So we see that 20% were less than 25 years old, 63%, 28 to 64, and 20% over 65 years old. And above all of this, country of heritage, we really asked by country, but I'm going to give you the little summary. So 43% of our sample, 42% of our sample were from Mexican or Mexican American origin. And we asked this question like that: what's your country of origin or heritage? People could select multiple of them. 10% of them were from Puerto Rico, 11% of them were from South America, 19% did not say the country, they just wrote Hispanic, Latino, or they left the question blank. 13% from South Central America, with a lot of representation from Salvadorians and Hondurans. And Caribbean, this one particularly includes Dominican Republic and Cuban. All of the responses went from the US. If they were particularly for the online responses outside of the US, including Puerto Rico, those were not considered valid and they did not complete the survey. Now let's talk about the results, but for that, let's go myth by myth. The first one, dementia versus Alzheimer versus memory problems. And we can get into a very detailed discussion on what each of these mean. But I wanted to, this is a conversation, the way that we ask it is about what is the best word that we can use to talk to people. One of my department has an institute called the Wisconsin Alzheimer's Institute. When we have a table in community events, people see the word Alzheimer's and run the other way. So this was part of the conversation. What's the right word to use? How do people refer to symptoms? How do people communicate about these things? So this is the thing that we learned. First thing, and this came from the interviews. Remember the 23 interviews and a small sample of the surveys. Most people, 64% of those that completed the surveys thought that Alzheimer's disease is a mental illness. And they describe it in this way. It's very complicated, it has stages, it progresses, it deepens, it is worse, and the person loses contact with reality. And that's not reversible. That gets complicated. The person really loses contact with the people around them. But then going a little deeper, we ask them, okay, is Alzheimer, and I want to direct you to the last point in this table. Is dementia different from Alzheimer's? 54% of them thought that yes, it was different. And this, at least 20% of these were people were caregivers or had somebody with a disease. And some of the comments were, I think they are two different things. They look alike, but they're not the same. Because, for example, with dementia, you begin to control it. It can be a chronic disease, but can be controlled. But on the other hand, in Alzheimer's is advancing. It's advancing very quickly with even more some medications that they are using. And then another of the common perceptions was that Alzheimer's was a stage after dementia. And why is this important again? This is important because when we are doing studies or we're inviting people to participate, we need to use the language that people is using. How can I invite somebody to participate with a dementia study if they do not think they have dementia? And this is one of the things that one of the persons in the interview say, oh yeah, my doctor told me they had dementia, but I don't think so. Okay. So what people think about Alzheimer's is more severe than dementia. This, I'll show you, 36% of the sample responded that yes, Alzheimer's is more severe than dementia. And 44% say, no, I don't know. But looking at the responses in the qualitative, usually people describe this as a spectrum, where you start having memory problems that are when you forget little things and might or might not affect your life, that starts to progress to dementia. And in dementia, your behavior gets affected. And one of the most common behaviors that people share was stealing. They were afraid of dementia because, oh, people is going to think that I'm going to steal stuff from them. I was afraid of that. And that was something that caught my attention. I don't know if that's just the experience that people have had or that people behaving in abnormal ways in public. So they were afraid of that situation. What will happen in public when somebody with dementia misbehaves? And then after that, it becomes Alzheimer's. That was the perception in many of the interviews. So that's just another interesting point that I wanted to share, because we can have 90 different thousand conversations about, is this Alzheimer's, is this dementia, is the memory problems, how can we make it more specific? But when we are communicating with patients and people, unless we use the language that they understand, they might not be receptive to the information. So now let's go down to the myths. Myth or reality? Latinos think dementia is part of normal aging. So again, this survey of 1,000 Latinos, 73% thought that at least somewhat normal to forget things with age. Remember, there's a perception that memory problems are on their own, dementia is something else, and Alzheimer's is something else. 73% of them thought that it's normal to forget things with aging. But when asking the question, is Alzheimer's normal of aging? 49%, almost half of them, thought that it is at least somewhat normal. At least somewhat normal. This means that is somewhat, very normal, or extremely normal. Of course, the extremely normal is just like 5% of people. I think this is it was like 35% of people thought it was somewhat normal. Then let's go a little bit down the other question. But the good thing is that 73% of them think that there's something that you can do to reduce your risk of Alzheimer's disease. And this is the exact language that I use, Alzheimer's disease. And in the survey, we had some questions related to dementia, some questions related to Alzheimer's. And in some cases, we asked both, the same question for both things. And sometimes we're the same, sometimes we're different. But the purpose of this survey was specifically for Alzheimer's. Now let's go a little bit more talking about those myths. First, myth or reality? Latinos lack awareness and education about Alzheimer's and related dementias. Think about it. What do you think is going to be the response? Well, I'm happy to report that 70%, approximately 70% of the samples, so about 700 people, correctly identify most of the symptoms and risk factors for dementia. There were variations, of course, of the risk factors and there were variations based on education level, and there were variations based on age. But in general, most Latinos have a decent awareness about their symptoms and have a decent awareness about the risk factors. This is what people think about the risk factors. And the question was, how likely is that somebody will develop dementia if a parent had it? 80% of them adequately said that having a parent with Alzheimer's was a risk factor. Poor sleep, 77% of them said that poor sleep was a risk factor. 62% said that the stroke was a risk factor. 58% referred that nutrition was a risk factor. Traumatic brain injury, 57% said that it was a risk factor. And this is where we get interesting. Hypertension, only 51% of them identified that might be a risk factor, or 49% referring that it might be a risk factor for diabetes. And when looking at the most recent, why this is important asking about the risk factors. When we look at the most recent Lancet review in dementia, we know that up to 50% of the cases could be prevented. And many of the things that we have in this list are also have been identified as very important in prevention. I'm thinking about specifically hypertension and diabetes. These are two that affect our Latino communities the most. These have been identified as responsible for the 4% at least of the global dementia cases. So if we can make a better case, making sure that this is not only about, oh, you are just hypertensive during your life and that's it, there's no other problem except for heart disease. Can we make sure that people take action about it? What do you think? I have the answer, don't worry. But the main thing, if you want to remember just one thing about this, Latinos have more knowledge than we believe. They are very good at recognizing symptoms and risk factors of dementia. So the lack of use for healthcare services might not come from motivations. This might not come of just that assumption that memory and cognition problems are part of normal aging. There's other factors at play. But let's go a little bit more of that prevention strategies, because this is something that really caught my attention. 90% of people thought that it was very important to get health symptoms early. As I said, this is not about something that people think like, oh, no, it's fine, there's nothing to do about it. 93% of them thought that it was important to get help for symptoms of memory early. 95% thought that it was very important to stay physically active. 96% thought it was important to stay mentally active. 92% thought it was important to stay socially active. But then we get to control hypertension. Remember, only 51% of them thought that hypertension was a risk factor. But then we see that 83% of them think that controlling hypertension is important to prevent dementia or Alzheimer's in the future. There's a little bit mismatch over there. And this relates to a perception that it's important to take care of yourself. We saw this in our interviews it was considered very important to take care of yourselves, and hypertension and diabetes management and other things were just one of the examples of how do you take care of yourself. So it's not, for me, it's not coming from motivation. This is not a lack of motivation. This is not that we need to fix Latino knowledge or Latino motivations. This is that there's other factors at play that people might not know when is the right time to get to care. or that when we are closing the doors, when people asking about things, and then we blame them. Now let's go about middle of the myth of reality. Latinos prefer home-based family care rather than institutional care. Again, I'm preaching to the choir. 92% thought that it was at least somewhat important. But I like this number, the next number better. 76% of the responses say it was very important or extremely important for family to be cared at home by family members. 76%. I knew this number was going to be big. I didn't know it was this big. And these hold even across ages, and these hold even across languages. There was a perception that, well, maybe second generation, those are more comfortable in English, they may have less attachment. They still thought it was very important. And one of the interviews that I did reflected this in such a way that I always say it. They mentioned, once my mom was diagnosed, we went to the doctor and he said that we needed to put her in a nursing. We never went back. Access to care also refers to access to care that's acceptable and culturally appropriate. And when we see that moment that the doctor offered nursing home, that trust was great. And who knows how long it took them to find a new doctor. But that's something that this particular point, yes, we knew this. I'm just very happy to see that it's not only empirical experience, it's also, we can see the results statistically. I love this one. Myth or reality? Latinos distrust doctors or Western medicine. Place your bets. Who's betting? Think in your minds. Do you think this is myth or truth? Okay, let's take a look. This is the exact question. If you were having memory problems that affected your daily routine, 92% of them thought that it would be useful to see a doctor. Not only that, 87% of them would like to see a doctor. And 80% of them thought that the doctor would be able to provide treatment for them and their families. So I can say, that was a myth. And this reiterates something that we've seen in other places. Latinos trust physicians and scientists. There's a high degree of trust. We can have a conversation about what is the care that they're expecting and what's the care that we can provide, because I think that's where a little bit of a mismatch. And remember, the nursing home, there may be a mismatch in the care that we provide, but there's a high degree of trust, and most people will find it useful and they want to see it and they want to go to the doctor. So again, motivations is not the issue. The misdiagnosis or the underdiagnosis, I think, is not on our patients or Latino side. I think this is coming from the system. And we will have enough time for conversations. But remember, chicken and the egg. Thinking about the chicken and the egg situation, I think the survey results that we just discussed and the survey there's a mismatch between what the clinic staff is expecting to happen and what people is expecting to happen. So patient might not ask about it because they don't know they can ask, but they would like to ask. In some of the interviews that I did not reflect, a lot of the people say, I just don't know. We have such a short appointment. There's never enough time. And we hear this from the primary care doctors too. There's never enough time. Somebody says, oh, I have this. I don't have time to take care of that. I have to do the hypertension. I have to do the quality measures. I have to do the diabetes. I cannot look into that. I don't know what to do with that information. So it's not about lack of motivation. It's not usually, I think it's the systems level. Clinics and staff also need to be prepared to work with Latinos in order to really go deeper into understanding what's happening. I don't know if you have had the same experience, but for me, when I see patients and I ask, how are you doing today? And say, oh, good, very good, doctor. Here, gracias a Dios. Okay, but you are in the clinic. Tell me what is bringing you here today specifically. Oh, well, I have this pain. So sometimes this understanding that we don't want to look, we are grateful for the life that we have. We are grateful for the opportunity to be here. that some doctors might interpret as, oh, there's nothing to take care, there's nothing else to talk about. But it's a little more of understanding. They want to have the conversation. They want to make sure that you ask them what's happening. Many times I go down the list. It's like, okay, have you had any headaches over the last couple of weeks? Have you seen this? Have you seen that? Because in one of the interviews, somebody said, if the doctor don't ask about it, it's not important. If the doctor don't ask me about it, it's not important. They don't know what is important, what is not, and sometimes they might be afraid of volunteering symptoms because they might not want to waste the doctor's time. That understanding of how patients and how the appointment might go differently is very important. And we need to train our clinic teams to really have that. And I might be preaching to the choir, but here, when we are working in Wisconsin, 6% of the Latinos only, and probably like 1% of the health professionals, that's where it makes a huge difference. When a lot of your care is relying on translators and interpreters, there might be a lot more things that are missed in translation. So what are we doing with this? Well, disseminating the results and making sure that the people that participated get them. That's part of building trust. These results should not be just for the conferences, but also we are right now working on sharing with our promotora teams and with everybody that completed the survey and help us recruit. Let's say, hey, this is what we learned, and we really appreciate everybody's input. We got people that send us email, like say, hey, this question, I was a little confused because I have a family member and I went through the journey. So some of the questions were about the symptoms were like, well, yes, it depends, or it's worse when you are higher in the more advanced in the journey. So we had a lot of interest about this. A lot of people were really interested, and I appreciate everybody. And if anybody that you hear participate in the survey, tell them that I'm very grateful for them sharing their input and their time with us. We are also analyzing to look at the different characteristics. We know that those we had lower literacy had lower knowledge, but it was not by much. It was, and particularly, it was statistically significant in the areas about prevention. Those with lower literacy had lower knowledge about how can we prevent things. But overall, they were pretty good about identifying the symptoms. Healthcare professionals have a high levels of trust. So part of also future steps is how can we work more with healthcare professionals to increase not only recruitment into research, but also improvement in care. So that when we do research that actually changes care and makes sure that people receive the care that they need, when they need it, where they need it. This is my email. You can find me on LinkedIn. I'm also on Instagram and previously known X, but happy to, we have a conversation now.
Well, that was great, Maria. It's a beautiful thing what you're doing. Congratulations. So I would like to open the floor to the audience to make questions. Well, I don't see the first question yet. Here's, okay, I'm now Manso. Raise hand, please.
Hi, my name is Alma Manzo. I'm from ASU. I'm a fourth year PhD student. And this is amazing work. My research is focused on Latino caregivers of people with dementia. And I wish this was published because this would really help my own paper right now. Your finding regarding wanting care in the home, wanting to stay in the home, rings really true to like the findings that I'm seeing as well. And my question to you is 6% of Latinos in Wisconsin, that's going to be an even lower number for caregivers or people with dementia. What was it like getting the recruitment for your interviews, the qualitative interviews?
That's a great question. And I wanted to say that my qualitative interviews were with older adults in general. They did not need to have a specific identify as a caregiver. But at the end, because of the topic, we got a lot of people that have experience providing care to somebody with dementia. So we got at least a decent amount. Even in the survey, we ask a question about, have you provided care? And about 25% of the sample provided care to somebody with Alzheimer's disease or dementia or other memory problems. But I think the hardest thing that we have had is the word caregiver. I'll be honest, this is the word that is being a challenge. And we have other studies when we have tried multiple different ways, but we end up always in a philosophical discussion. And there's a couple of people from my team here that I'm very grateful for the input, because how do you define a caregiver? Is a 5-year-old that's translated for their parents all of the paperwork, is that a caregiver? They are providing care to our parents. They're 5, but they're translating. So, and what are the responsibilities and I know there's other studies referring to this, but where does the being a daughter ends and becoming a caregiver starts? Oh, I drive my parents around, or I take care of the finances just because I'm their daughter. No, I'm just making their life easier. Is that a caregiver? And I think there's multiple definitions, but in one of our studies, it came down to many people that's providing care does not identify as a caregiver, and we have been having a hard time reaching them because of the word caregiver. And even when we do the list, hey, if you provide help to somebody because of they have a difficulty in physical need or a mental need or a social need, if you provide any help, even if a short term or long term, we would like to talk to you. It's been hard. It's been really hard. We relied a lot on connections in our people sharing the word, but that's one of the reasons why the survey went out also to all of the United States, making sure that we have not only people from Wisconsin filling it out, but that we can really try to get as many people as possible identified. Thank you so much for your question. And I'll make sure to publish this very quick. I promise.
Yeah, thank you. One follow-up question. Did you work with any organizations? You said, you did this outside of Wisconsin as well. What kind of organizations did you work with?
Great question. In LA, we work with a group called LA Woman. They have a group of promotoras that they work on different groups of, different topics of health. They have worked a lot in diabetes before, and I got connected to them thanks of a partner, and it was a great collaboration. They were about 12 promotoras. Each one of them recruited about 10 to 15 individuals, and one of the main things is that I can say they were able to recruit a lot of people with lower literacy. And one of the main things that they share why that was important is that many people was afraid of filling the survey. They did not want to make a mistake. Even though the survey say 25 different times, there's no right or wrong answers. We just really want to know what you think. People were afraid of making a mistake. Having the promotoras working with recruiting people, not even recruiting, but sharing with people and say, it's fine, don't worry. This is not about if you're right or wrong. We just really want to know what you think so they can do things about it. That was extremely important. And we saw the same thing here when we working with the interviews and other things like that. People is afraid of making an error. And that's why they working with that group was very important. We work also here in Wisconsin with a couple of senior centers, and having the people that work in the senior centers that knows us and knows the participants say they're fine, it's good, don't worry, go ahead and fill it out. That was extremely important for us. In Chicago, we work with a medical professional organization that is particularly interested in pipeline programs for Latino students and Latino students are interested in health careers. Through them, also they have connections to health fairs and other organizations. The LiveServe has like 5,000 people, so through them we also recruited. And the last thing that we use particularly were a couple of other partners in Houston and Puerto Rico, that people that's been working on dementia investigators for a long time, and they have already sort of an outreach protocol. So we partner with them to reach out those communities in Houston and Puerto Rico. I'm happy to share their names. So if anybody wants, yeah, they're tested. I work with them. They're good.
Yeah, that's amazing. Thank you so much.
Okay. Any other questions from the group? Okay, Jesus, you're talking.
What would you think would be or what are gonna be your next steps?
So Next steps. That's I like to usually to say I'm a jack of all trades, master of none, in the sense that in order to improve care, I already show with this, it's not the patients that need fixing. It's not, period. And we can have a discussion of, oh, well, we need to increase the knowledge. Absolutely. We need to increase knowledge, particularly about the prevention factors. We need to increase knowledge about when to seek care. Yes, definitely. I have, but that's not the main thing. The other thing that we hear is that people say, when I ask my doctor things, he looks annoying. He doesn't, I don't want, so that's that interaction, that's where we're going for. We're working right now through my K99R00. We're working with community health clinics around the US to identify what's happening. Is it that doctors don't know what to do when somebody says this? Is it that they just don't have the time? Or is it that they know they not gonna have the resources to provide care, and that's where the annoyance comes from? Or what is it? So community health centers are responsible for taking care of 35% of Latinos in the US. They are in general, as a type of organization, they are the largest healthcare provider in the US. So that's why I'm starting with that group. But it's not only going to be understanding what happens in the appointment, but how hard it is to change the appointment. So we in a for-profit system and even a non-profit system, then the US still works in the same way, in the non-profit way, where a physician or a clinician needs to see a certain number of appointments per hour in order to make ends meet. How can, considering those restrictions, how do we can make the appointment better? Is it that we need to do more work before the appointment? More tests before the appointment, so the doctor only needs to do the review to be able to provide a diagnosis and spend a little more time on education? Yes. Is it that we need to have more team members, like health educators, to provide more time and more of the coordination? Is it that we need more social workers in clinic? Is it a combination of all of the above? Or is something completely different? Do we need to change how physicians perceive dementia in the first place? So that's the next step, because I don't know the answer. I have ideas, but
yeah, it's okay. And that was going to be with a follow-up question, because you made a comment about that they were scared of making a mistake, making errors while filling out the interviews, and then once they ask the person who knew them, and that person says, "Go ahead, it's fine, you can go." Nothing's gonna happen. Then they feel more confident in the questionnaire. So what that reflects is just that if there is a person in between who they trust, and that's just the person. So you mentioned carers of promotoras, they can gather the information in certain communities, a certain group of people that will later on benefits for treatment. I'm sure they will be able to collect more of those information that the patients, or let's talk about patients that they require, and then that they can get that information, summarize information, or design a plan, and then discuss that with primary care physicians so they can take action. But just that the person in between, and it's not a translator, because if they're going to have a clinical appointment, the translator, that actually I believe will make things even harder. So there's a loss in the translation. Also, there's that kind of confidence there. But this person that you mentioned, like, I'm scared to answer, but that person says, "Go ahead, that's fine." But they knew the person, they trust that person. So that was going to be my follow-up question. She just commented on that part about the next steps. All right.
And we have, there's one of the clinics here in Wisconsin that they have 17 years of experience. They are a community organization. They are not a healthcare center. They have a memory clinic. And they have that. They have somebody that does outreach and makes sure that is that connection to people. One of the things is that that's not sustainable because of the funding, the way the reimbursements work. Having a person external to the team doing outreach and gaining trust is not sustainable. The centers need to pay for it, and because it's not reimbursed by Medicaid, Medicare, insurance, it cannot be done. So it's about thinking about, okay, in an ideal world, money should not be an issue. But in a world where money is an issue, what can we do under these rules?
Yeah, that's true. All right. Huh. That's a tough one. Thank you, Maria, for those are great presentation.
Thank you for your question.
Yeah, well, I think that that part of the work is where research comes to play a big role, because when we have projects that can pay for some things that are provided to the person, at the end, this model, what you're following, is very good, is really sustainable at a certain point. If we can extend the research after just the determination of the need. And or the other option would be just to make an NGO organization that will find funding for these activities. I don't know, maybe through Alzheimer's Association, they have some funding that could be also requested. But yeah, it's very interesting. Something that is self-sustainable is definitely a must. And it's important because we are coming with different minds from a different place in the world when we have experienced how things can be different from the only perspective of the 20-minute approach to the patient that is covered by an insurance. That's very, it's very humanly good. So that's a part. I really appreciate your putting this, because it is a topic that we have been touching many times here and other places, and definitely is a must. We have to humanize the medicine and the attention, especially to the elderly people here. Beautiful. Any other questions from the audience? Let's see.
Well, I ask a question of the audience, and I would love if people use this. I think everybody can use the chat. Yes, I would really appreciate everybody to prepare to put an answer in the chat. And my question is to you, what was the most surprising thing that I discussed today? I'm giving you a minute to think about what was the most surprising thing, or what's a question that remains that, oh, you said this, but what does it mean about X or Y, or what about this? And take a minute, because this will really help me on, I don't want to preach to the choir. When we publish these results, I really want to make sure that we go to what is most needed. What is the something that really was interesting that will help to move your points forward or your research forward? Because I've been in the point where, wait, why are you doing that way? Because that's culturally appropriate. Yeah, but what's the paper that shows that way that's culturally appropriate? So I've been there. I know that having something, as Alma mentioned, having something that we can cite and say, this has been shown, this is not only me saying it, is really helpful. So now, whenever you get a chance, 5 more seconds, I'll ask you to put in the chat that what was the most surprising point that you saw today? 5, 4, 3, 2, 1, click hit, enter. Please.
Should I type it or can I tell you? Should I type it or can I tell you
Either way, whatever you prefer.
I think your main point was that I'm surprised about your main point. Like I had the impression that we just have to give information and try to educate about what is the problem of having all these risk factors, but I didn't know that there was actually the other aspect that they already know. I mean, they have a good knowledge or basic knowledge about what those risk factors can do. I had the other different mindset, like we need to disseminate or give more information, but I didn't see the other one coming. Yeah, to be honest.
Thank you so much for sharing that. And that's very important. I think also I will tell you, I was surprised. The knowledge was higher than I expected. It was higher than I expected. So again, that's just confirming that it can be improved in certain areas, but people know.
Yeah.
People really know.
Yeah.
Yeah, sorry. Thank you to everybody that's sharing what was the most important, most interesting factor. I really appreciate those comments. One of the comments that came privately to me was, it was interesting, the issues encountered with collecting information, people being afraid to answer wrong in a survey. I want to expand that a little because we also saw something, particularly in our Houston populations compared to Puerto Rico. It was the same group doing the approach. It was people that has known in the community, has worked in the community before, but particularly in Texas, there was another fear beyond the survey, and many of you might have experienced this. It was, I don't know what you're gonna do with this data. And even though I don't ask personal information, people say, I'm not wanna be at risk of endangering somebody in my family that might be tracked through me in some other way. In Puerto Rico, the same group did the approach in Puerto Rico and Houston, and both of them were, both of them did the same approaches, but it was in Puerto Rico, there's not an immigration issue. They were not afraid of deportation or of losing Social Security or things like that. That was so in Houston. And even though, again, it was a group that already worked in the community for several years, they were put in multiple partners, and even the partners said, I don't know why Wisconsin is here. Why are you getting people, why is Wisconsin here? So it turns out that also that was a point of distrust. Here in Wisconsin, seeing the logo of the university gave us automatic credibility. In Houston, automatically distrust. Why are those people here? So that's one of the things that we learned. Did the people that have the same sensitization with the surveys offer an incentives? All of our surveys offer an incentives. All of our surveys, regardless of who applied it, have the $15 gift card. And that was not enough to overcome hesitation. And I think one of the other things that we learned in that collecting the information, the aspect, particularly in person, besides the fear of answering something wrong, we have also the group of people that, and as I mentioned, the survey did not reflect their experience. They had been in the journey, they have cared for somebody, and they wanted to be provided more details on, well, when they were at the early stage, yes, they had the symptoms. When they were advanced stage, no, they didn't have that. So, and that's a problem with the surveys in general. The survey is not designated to really explore that experience. And we got a couple of emails about that saying, you should do a qualitative study because the survey is not representing all of the things that I went through, and say, yes, you're right, 100%. And we have a different study for that. One of the things that also we know, and we are actually recommending now when they're collecting the information and the survey, the issue for us also, we have it in English and Spanish. We had the survey online. We have the promotoras. We also had an option to fill it out over the phone for those that have trouble with the online survey. Nobody used the phone. Nobody. The extra step for having a phone call, yeah, that doesn't work. So if it's not in person, right away, right there, fill it out later. Yeah. So there's just a little tip. Thank you for other comments that one was interesting. Awareness of the resources of use of Western medicine, distrust of physicians being a myth, sustainable mechanism to provide kind, extra care in America. Define caregiver. Growing up, translated from my parents, I never thought of as a caregiver. And I think that's, again, we end up in a philosophical discussion, and every time that I bring this up, people look at me like, what? Because that's the most important thing of why we need our voices represented. If you have not seen something different, if you have not been part of the journey, if you have not experienced something different, how will we know to fix things? And remember that Latinos, the number of Latinos with Alzheimer's disease and dementia will grow in 900% over the next 30 years. Right now, there are about 350,000 Latinos with Alzheimer's disease in the United States. That number will become 3 million by 2060. If we don't prepare for that today, we are not going to be ready. It takes 15 years to train one physician. 15. We need to be ready. Somebody else had a comment. the distrust. Okay, I'm gonna make sure that I talk about more about the distrust. I think we have seen in other studies that also there was this very good trust, but this might change by locations. More TBD on that one. In California, we have very good trust, for example, but also California has recently they do Medicaid. They expanded to undocumented. So there's this difference. Here's where the policies at the state level affect how people interact with the system. Thank you everybody to making a comment. I will make sure to emphasize these points. Any other questions?
Oh, this looks very nice, and it was very, very interesting talk, Maria. It's a nice reflection and makes everybody to think about. So I think it's not only to be able to say something, but also to put people to continue thinking about your work afterwards is the most important thing. So I think everybody here is now available. Thank you for sharing your email. That's very nice too. We will have the recording available for everyone who wants